This is QD Clinic, and I'm Jack Cush with RheumNow. QD Clinic is brought to you by RheumNow.live 2025, February 8th and 9th in Dallas. Meetings like this matter. Meetings like this change your thinking and practice. Today's case is a 40-year-old woman who presents back in March. Oh, that's like 10 months ago, 9 months ago, with a few swollen fingers that were puffy. And she had a swollen left knee. And she had rainouts. And I had no other results. I had no other labs. I gave her prednisone, a taper, and I brought her back in 2 weeks after labs. Her lab showed that she had an ANA that was positive at 1 to 320. That was in a nuclear, speckled, and cytoplasmic pattern. What are you going to do with that? She had a normal SED rate in CRP in spite of having what looked to be inflammatory arthritis. She was seronegative for rheumatoid factor and CCP. She had a mild anemia, and her CPK, SED rate and CRP were normal. So further history was negative. She had some dry mouth, maybe some mild dry eyes. And I started her on methotrexate, assuming that this was early inflammatory arthritis with lupus or maybe seronegative RA. Not too clear, maybe an overlap. But she, 6 weeks later, had sudden severe shortness of breath. Went to a walk-in clinic and then went to the hospital, was hospitalized for, I think, almost a month. In the hospital, she was seen by pulmonary. She had lots of imaging, testing, and a lung biopsy. She was found to have interstitial lung disease with organizing pneumonia. And yes, the pulmonologist stopped her methotrexate. Further testing in the hospital again showed the ANA positive, but she was now also SSA, SSB, and JO1 positive. So in the hospital, she complained of malar, or was found to have malar depigmentation, gastritis, continued joint problems, but compared to the lungs were the big problem. She was, like a bad asthma attack, gasping for air, needing oxygen. This was the dominant issue. She was given a pulse of steroids, sent home on high-dose steroids and mycophenolate 1,000 milligrams a day. So I see her 4 weeks later. Oh my God, what happened to you? And when I see her, the lung problem is no longer a problem. The steroids and the mycophenolate made a dramatic difference, but she's got horrible polyarthritis. She's got 30 tender joints. She's got 12 swollen joints. She's on prednisone, at that time 20 or 30. Mycophenolate. And the question is, what are you going to do with this? So I looked at this and said, well, I got to treat the arthritis. She clearly has the anti-synthetase syndrome and ILD, but I'm not so clear about whether she has myositis or not. So I am going to order a CPK. And I get back to CPK and it's 2,000, and her AST and ALT are 3 times the upper limit of normal. So I put her on leflunomide. The pulmonologist stopped the methotrexate. I like using methotrexate and leflunomide in inflammatory myositis. The leflunomide will treat the arthritis, will treat the inflammatory myositis. I put her on an IL-6 inhibitor, and I want to get her off the mycophenolate. And that's exactly what I do, and she does great. The swollen joints go down dramatically. She gets much, much better. But when she finally stops the mycophenolate, the joints come back. She has a rash that comes back. It's on her face, on her chest, extensor surfaces of the arms, and she has got periungual erythema. So her dermatomyositis is back, although she's not weak, and her CPK has gone down progressively from 2,000 to 600 to 178 to 35. And the question is, what are you going to do with her now? When I asked this question on a Twitter poll, I asked, what would you use in an anti-synthetase overlap patient with myositis, synovitis and rapid ILD, and 62% said they would use mycophenolate. It seems like her ILD has not been the problem. Her chest x-ray on repeat looked much, much better and barely showed signs of ILD, but that might not be the best way to follow that. But she's asymptomatic. She can climb stairs. She's not weak. So what I did was I put her back up on prednisone. I got her prednisone down to 5 and off of mycophenolate. I put her back up on prednisone 20. Instead of putting her on mycophenolate, I'm going to put her on a JAK inhibitor. The JAK inhibitor will, I think, treat the muscle disease and the arthritis being the big problem. Am I worried about the ILD? If I was more worried about the ILD, I probably would put her on an ILD drug like the mycophenolate. So what do the guidelines say about what you should do with ILD? And in that case, mycophenolate and IL-6 would be okay. The expert opinions, which, by the way, were all conditional recommendations, not grade A evidence or even grade B evidence, say that first line treatment of ILD in this situation is mycophenolate, then rituximab, cyclophosphamide, and azathioprine. If they have MCTD or scleroderma, you should use the FDA-approved IL-6 inhibitor, right? That makes the most degree of sense here. If they have a rheumatic disease, they say you shouldn't use a TNF, leflunomide, methotrexate, or abatacept because those don't treat ILD. But these are all conditional recommendations. So I'm banking on the fact that she's got an overlap syndrome, an anti-synthetase syndrome with a dominance of polyarthritis, myositis, and a worry about ILD. My future therapy, I believe, is going to be a JAK inhibitor with or without leflunomide. And I'm going to get her off the prednisone. I'm going to get her off the IL-6 inhibitor. Be interested in knowing what you would do. Tune in for more QD Clinics.